Between 1950s and 1970s, typical antipsychotics or the first generation antipsychotic drugs were the mainstay in management of schizophrenia. Research and development then led to the introduction of atypical antipsychotics, of which the prototype is clozapine. So clozapine was actually discovered in the 1970s, but only introduced to the market in the 1990s. There are, of course, many other different atypical antipsychotics used to treat schizophrenia as well as bipolar disorders, and this include aripiprazole, risperidone, ziprasidone, as well as olanzapine. The primary distinction between typical and atypical antipsychotics has been made on clinical basis. As you know, typical antipsychotics are characterized by undesirable side effects such as extrapyramidal symptoms, hyperprolactinemia, tardive dyskinesia, and possibly neuroleptic malignant syndrome. So all of the symptoms are specific to the group as a whole and generally associated with high doses, but in some cases also at clinically effective dosage. So the second generation, or rather the atypical antipsychotics, can be differentiated from traditional antipsychotics by their low or negligible levels of these unwanted side effects, by effectiveness, and in general supposed increased safety profile. Clinically, the atypical antipsychotics have lower incidence of extrapyramidal symptoms, tardive dyskinesia, and hyperprolactinemia, yet they are equally effective as typical antipsychotics in reducing the positive symptoms of schizophrenia. They are more effective at reducing the negative symptoms compared to typical antipsychotic drugs. And although in general it is supposedly associated with increased safety, that's not entirely true as well, as they have been linked to metabolic syndrome, or rather the development of metabolic syndrome, which we'll talk about later on. D2 receptor antagonism or D2 receptor blockade in the brain is a general pharmacodynamic property of all antipsychotics, and without it, a drug will not show any antipsychotic property. And this is also true for atypical antipsychotic drugs. So for the atypical antipsychotic drugs, D2 receptor antagonism is still present and is a critical characteristic underlying its effectiveness as an antipsychotic. However, there are of course differences in terms of its pharmacological profile. First and foremost, the atypical antipsychotic drugs shows serotonin binding ability, or more specifically, it is an antagonist of the serotonin 5-HT2A receptor. And this is an important characteristic because in the brain, dopamine and serotonin actually plays a role hand in hand in the balance of mood and other CNS function. So the atypical antipsychotics, as I've mentioned, they are able to block the serotonin 5-HT2A receptor. Additionally, the atypical antipsychotic drugs bind more loosely than dopamine to the dopamine D2 receptor, with dissociation constant higher than that for dopamine. And on the contrary, typical antipsychotics bind more tightly than dopamine to the dopamine D2 receptor. So essentially, in a simpler sentence, the atypical antipsychotic drugs is rapidly dissociated from dopamine D2 receptor as compared to the typical antipsychotic drugs. And as a result, this has resulted in quite a different profile of side effects if you are going to compare typical and atypical antipsychotic drugs. So again, to recap, from a pharmacological perspective, the current atypical antipsychotics as a class are defined as serotonin dopamine antagonists with simultaneous serotonin 5-HT2A receptor antagonism that accompanies D2 antagonism as shown here in this figure on your right. And it is this additional serotonin antagonism that mediates the atypical antipsychotic clinical profile of low extrapyramidal symptoms and less hyperprolactinemia with comparable antipsychotic actions. And each of these mechanisms will be discussed in the next few minutes. Another characteristic that makes an antipsychotic atypical is the fact that it dissociates faster from the dopamine D2 receptor as compared to typical antipsychotics. So basically, the fuss of theory of atypical antipsychotic action is that the atypicals have lower affinities for dopamine D2 receptor, as you can see on the figure on the right here. And basically, this means that they are loosely bound to the receptor, and thereby they can be rapidly released from this receptor. A critical aspect of the theory is that the atypical antipsychotic binds more loosely to D2 receptors than the dopamine itself, while traditional typical antipsychotics bind more tightly than dopamine. And this is in fact, one of the reasons why atypical antipsychotics have a different side effect profile. In vitro binding experiments have actually shown that clozapine, quetiapine, as well as amisulpride, which is the newer generation or which are the atypical antipsychotics, quickly dissociated or were quickly displaced from human clone D2 receptors. And in contrast, haloperidol as well as chlorpromazine were displaced much more slowly from the D2 receptors compared to the atypical antipsychotics. Atypical antipsychotic drugs are equally effective as typical antipsychotics in reducing the positive symptoms of schizophrenia. They also have the advantage of being more effective at reducing the negative symptoms of schizophrenia compared to typical antipsychotic drugs. Additionally, they differ in terms of their side effect profile, in which they are associated with lower incidence of extrapyramidal symptoms, tardive dyskinesia, and hyperprolactinemia. So let us now take a look at the rationale for each of the atypical antipsychotic drug effects I have mentioned earlier. The effectiveness in reducing positive symptoms or in alleviating positive symptoms is due to D2 receptor antagonism in the mesolimbic pathway. And in the mesolimbic pathway, 5-HT2 antagonism of atypical antipsychotic does not interfere with the antipsychotic action. The decrease in negative symptoms or its effectiveness in reducing negative symptoms is due to enhanced dopamine release as well as 5-HT2A receptor antagonism in the mesocortical pathway. And with regards to its side effect profile, the decrease in the risk of developing extrapyramidal symptoms as well as tardive dyskinesia is due to rapid dissociation of D2 antagonists from the D2 receptor and 5-HT2A antagonism in the nigrostriatal pathway. And the decrease in the risk of developing hyperprolactinemia can be attributed to 5-HT2A antagonism in the tuberoinfundibular pathway. And we'll talk about each of these mechanisms in more detail in the next few minutes. Typical antipsychotic drugs are known to cause extrapyramidal symptoms, and this is due to its antagonism of the D2 receptors within the nigrostriatal pathway. Whereas the atypical antipsychotic drugs have a lesser risk of causing extrapyramidal symptoms. Let's compare what happens when you have both typical and atypical antipsychotic drugs. The typical antipsychotic drugs or the first generation antipsychotics are known to have a high affinity for the D2 receptors. Consequently, once they are bound onto the receptor, it is quite tightly bound, and as such, they very slowly dissociate from that receptor. And because of this constant antagonism of the D2 receptor, This would lead to the development of extrapyramidal symptoms. On the other hand, if you have atypical antipsychotic drugs, such as quetiapine, which is one example of the second generation or newer atypical antipsychotics, they have a very low affinity for the D2 receptor. So although they do have antagonistic property on the D2 receptor, they are quite loosely bound onto the receptor and dissociates quite fast. Consequently, because it dissociates faster as compared to the typical antipsychotic, there is less risk of the extrapyramidal symptoms developing with the atypical antipsychotics. Aside from its rapid dissociation from D2 receptors, atypical antipsychotics are also known to have a lesser risk for causing extrapyramidal symptoms due to its 5-HT2A receptor antagonism. So how exactly does this happen? If you block the D2 receptors within the nigrostriatal pathway, this would result in extrapyramidal symptoms. However, with the presence of 5-HT2 antagonism property, the atypical antipsychotic drug would block the 5-HT2A receptor. This inhibits dopamine release and consequently reducing dopamine 2 receptor blockade. To further understand the role of serotonin within the nigrostriatal dopaminergic synapse, let's take a look at this figure. In yellow is dopaminergic neuron projections from substantia nigra to the striatum, which is the caudate and putamen. And the release of dopamine from the substantia nigra is essential for normal motor function. Dopamine is balanced by the presence of serotonin. Serotonin is released from the serotonergic neurons of the rough nuclei, and the released serotonin would then activate the 5-HT2A receptor on the presynaptic dopaminergic neuron. The activation of 5-HT2A receptor would then inhibit the release of dopamine. So this is what happens during a normal situation. Typical or older generation or conventional antipsychotics, however you wish to name them. For instance, haloperidol, which is one of the older ones, they are all D2 antagonists, and it would then cause blockade of the D2 receptor within the nigrostriatal pathway. If occupancy or if blockade of D2 receptor reaches 80% of the dopaminergic D2 receptor population, then there would be the development of extrapyramidal symptoms. This is what happens when you have a typical antipsychotic drugs. So again, typical antipsychotic drugs are D2 antagonists, and consequently, the blockade of D2 receptors within the nigrostriatal pathway, and especially if the blockade reaches 80% or more of the general population, this will result in the development of extrapyramidal symptoms. Atypical antipsychotic drugs are known to have antagonistic property on both serotonin as well as dopamine receptor. So in a way, they do have the ability to then block the D2 receptor within the striatum, and this could potentially lead to extrapyramidal symptoms development. However, because of its antagonistic properties specifically on the 5-HT2A receptor, it means that the binding of atypical antipsychotic drugs onto the 5-HT2A receptor and its consequent antagonism would remove the inhibitory mechanism on dopamine release, and consequently you would have more dopamine within the synapse. And the result of this increased dopamine release is that there would be more dopamine to compete with the D2 receptor antagonism within the striatum. So this dopamine would displace the antagonism and thereby reducing the D2 receptor binding to below 80%. And this is actually enough to reduce the risk or to eliminate extrapyramidal symptoms. So again, 5-HT2A receptor plays a role in the negative feedback mechanism on dopamine. When you have 5-HT2 agonists, it would result in a decreased release of dopamine. However, if you have antagonism of 5-HT2A receptor, you remove the negative feedback mechanism and you would have more dopamine being released, consequently displacing the antagonism of D2 and thereby a lesser risk of developing extrapyramidal symptoms. Aside from the decreased risk of extrapyramidal symptoms and tardive dyskinesia, atypical antipsychotic drugs are also known to decrease the incidence of hyperprolactinemia, unlike typical antipsychotics. And this can be attributed to its 5-HT2A antagonism in the tubero-infundibular pathway. Dopamine inhibits prolactin release from the pituitary lactotroph cells when it binds to D2 receptors. On the other hand, serotonin stimulates prolactin release when it binds to the 5-HT2A receptor. So serotonin and dopamine have reciprocal regulatory action on prolactin release. The typical or first-generation antipsychotics are D2 antagonists, and consequently, it would oppose dopamine inhibitory role on prolactin secretion from the pituitary gland, and this would result in an increase in prolactin release because the role of serotonin is now unopposed. The presence of second-generation antipsychotics are known to have both antagonistic property on D2 receptor as well as 5-HT2A receptor. So they would produce little effect on prolactin release and thereby lesser risk of causing hyperprolactinemia as compared to the typical antipsychotic drugs. Although a conventional antipsychotic can only decrease dopamine and will do this at D2 receptors throughout the brain, atypical antipsychotics with their additional 5-HT2A antagonistic property have much more complicated net actions on dopamine activity, since they do not only decrease dopamine activity by blocking D2 receptors, but they can also increase dopamine release and thus increase dopamine activity by indirectly stimulating dopamine receptor via the 5-HT2 antagonism action. However, these actions seem to be very different in different parts of the brain. In the nigrostriatal dopamine pathway and in the tubero-infundibular pathway, there is sufficient dopamine release by atypical antipsychotics to reverse, in part, the unwanted actions of extrapyramidal symptoms and hyperprolactinemia. But this does not appear to occur in the mesolimbic dopamine pathway, as antipsychotic actions of atypical antipsychotics are just as robust as those of typical antipsychotics, and this is presumably due to regional differences in the way each 5-HT2 receptors can or cannot exert control over dopamine release. So basically what the clinicians are doing or what the researchers are doing is they are trying to exploit these differing regional pharmacological mechanisms to get the best clinical results by simultaneous blockade of D2 receptors and 5-HT2A receptor. In spite of the various perceived advantages of atypical antipsychotics, bear in mind that they do come with their own set of side effects. So atypical antipsychotics are not just simply serotonin dopamine antagonists, they actually have very complex pharmacological properties. So these agents would act on multiple dopamine and serotonin receptors as well as histamine, norepinephrine, and cholinergic system. And this would result in various adverse effects that we will talk about in the next video.